Hello, my name is Ashley Davis, and I'm a DNP student here at Maryville University. Today I'm going to be doing a presentation on my scholarly project with the title of Reducing Body Mass Index in Overweight and Obese Adolescents. My chairperson was Dr. Rita Wunderlich, and my community member was Dr. Janine Jones. A little bit of background of why I chose to do and work on this concern is that 14.7 million children and adolescents are considered to be overweight or obese, according to the CDC guidelines. North Carolina, which is where this project was implemented, is considered to be the 8th highest state of adolescent obesity between the ages of 10 and 17. This is a 21% diagnosis of this chronic disease known as obesity. Populations with higher than normal body mass index or BMI are at a higher risk of chronic diseases such as your dyslipidemia, your fatty liver disease, and also type 2 diabetes. Adolescents are being diagnosed with these chronic health disorders and placing them at a higher risk for developing cardiovascular disease in early adulthood. The project's purpose is to increase awareness of healthy eating habits and exercise to improve the overall health of adolescents. The project's aim was to provide statistical evidence by improving physical activities and choosing healthier food options to reduce the adolescent BMI in returns of reducing their risk factors. A literature review was conducted, and through that literature review was pulled 3 different themes. These 3 themes, let's go back. There were 16 articles that were grouped into these 3 themes. The first one is adolescent overweight and obesity risk factors and associated complications. And then we have interventions and prevention. And then the third one is improved patient outcomes in the adolescent population. The theme selected provided the most guidance to support the scholarly project. The literature chosen supports current primary research studies with evidence of reliable and significant data. The objective of the review was to find evidence-based research to support interventions targeting adolescents in need of education and resources to aid in reducing BMI measures. The ARCS model was used to motivate adolescents to make a change in their health behavior. A, the participants must become engaged and interested in making a change before they proceed to the next component. Education through visuals such as growth charts provided this insight to the participants related to their personal health in comparison to the rest of the population. R is relevance. Relevance is providing material that is relevant to the learner in relationship to the subject matter that identifies a clear direction. Relevant material that was used is current evidence and research that provides real data to participants. C, confidence. Confidence, the learner must be confident and self-efficient through guidance and feedback. This step was achieved through providing resources for adolescents in rural areas. S stands for satisfaction. The learner strives for reinforcement and acknowledgement to reach and set goals for achievements. So reinforcement was met through BMI follow-up appointments followed by achievements of their progress. This quality improvement project was a quantitative exploratory design that was used through a retrospective chart review. The data for the project was extracted from the electronic medical records, or the EMR, on the adolescent patient population that are by guidelines considered either overweight or obese. The data compared pre and post interventions of lifestyle changes measuring the weight status and BMI. When looking at the sample, there were 42 electronic medical records that were obtained for this project. As I said before, the data for the project was extracted from the electronic medical records on adolescent populations that were considered obese or overweight. It encompassed all genders to be included in this data collection. The data was extracted only on adolescent patients between the ages of 12 to 18 years of age that had a BMI 85th percentile to 94th percentile that were considered overweight according to CDC guidelines, and then the BMI of 95 or above percentile is considered to be overweight according to CDC guidelines. As I said before, 42 EMRs were used and reviewed for this project that met the inclusion criteria. And a little bit more about that inclusion. The patients were seen in the clinic between the dates of August 2025 through December 2025, giving us a 3-month period to see these patients for their initial visit and their post visit. Education was printed off and given to these patients at their initial visit as a resource. And the pre-intervention weight and height was collected, which gave us that BMI at our initial pre-intervention visit. A growth chart was discussed and showed as a visual to each of these patients at their initial visit. And then the nutrition, if there was a need for a nutritional referral, that was also placed at the initial visit. As they come back 3 months later for their post-intervention, weight and height and BMI was collected at that initial visit. Or not at the initial visit, at the post-visit. Descriptive statistics provides an insight into the findings that are associated with this quantitative research project. Central tendencies were measured through the process or through the use of the descriptive statistics that were collected. The data was collected through the EMRs, as we said before, and then it was also de-identified and transcribed into a data collection sheet. That data collection sheet was imported the data to an Excel document using nominal data into categories. A z-test was used to determine the statistical significance of the pre and post intervention BMI measurements. The study was then analyzed using SPSS and Excel. A Wilcoxon sign rates test was used for the pre-intervention mean compared to the post-intervention mean of BMI percentage measurements. On this slide, we have two tables that show the Wilcoxon sign rates test that was used through the implementation of additional education on risk factors of increasing BMI and how to reduce BMI to prevent further complications. There was not a statistical significance indicated using the Wilcoxon sign rate test. The Wilcoxon sign rate test resulted in a Z statistic of negative 0.649 with an associated p-value of 0.516, as you can see there in that first table. Shown in the second table, the results of the decreased BMI categories had a total sum rate of 7.5 with a mean rate of 2.5. The results of the increased BMI categories had a total sum rate of 13.5 with a mean rate of 4.5. This chart shows a graph That gives you a little more insight of the pre-intervention numbers versus your post-intervention numbers. In our pre-intervention, this gives you our categories too at the bottom where it shows you your BMI that is less than 95%. Pre-intervention, we started out with 0 out of the 42 participants, whereas we ended with 2 participants that had decreased their BMI and fallen down a category in their BMI categories, so they are now considered, those 2 are not considered overweight anymore. So then in our if you look at the next category of 85 to 89%, 3 pre-interventions were in that category where we ended with 2 in that category. We were 6 and 6 for the BMI category of 90 to 94%. And then when we get to the 95 to 100% category, that category is considered to be obese. And we started out with 33 participants there and ended with 32 participants there. The results show no statistical improvements in the BMI grouped categories after the implementation of additional education post-intervention. This graph shows post-intervention compared to pre-intervention with 3 negative rates, 3 positive rates, and 36 stayed within the same category. So 3 of the positive, yes, decreased within their categories. 3 increased their categories. However, when we look at the second chart, or the second graph, the figure was developed to show that there was a significant decrease in individual BMI that was not placed in BMI categories. So that grouped categories of that percentage between, so if we go back to this chart, we see that it was 85 to 89%, 90 to 94%. That grouped category, we broke those out into individual 85%, 86%, 87%. And once we did that, looking here, we did see a decrease in individual BMIs that were not placed in those groups. So if you look here, 18 participants of the 42 participants, which actually made it 42% of the participants, actually decreased their BMI post-intervention. So with this 42 it reveals that a decrease of 42% post-BMI measures may indicate that a longer time frame would show a significant improvement within those BMI grouped categories. With such a short time, it's hard to see a person or a participant jump from a grouped category down to another one versus individual. So here we did see a decrease, whereas 14 participants did stay the same in the same BMI category or the weight change, and then we did see 10 of them did increase in weight. Moving on to our limitations, as I just kind of touched a little bit on right then, the first one was time. Time was the most significant concern in this study due to the time frame it takes to actually reduce one's BMI. Implementing a lifestyle change and observing a significant decrease in BMI typically takes longer than the allotted time frame of 3 months that we had for this project. So the range of BMIs were grouped, as we said, in categories, did not show that statistical significance. However, I do feel that maybe a longer time frame would show that improvement within those group categories, considering we saw that difference with that individual broken out BMI change. Our next was lack of resources. The lack of resources located in a low income area, which is where this project was taking place. But if you look back at going back to all the research that was done in the literature, throughout the literature review, the low income areas are the areas that have the higher rates of obese and overweight adolescents. But that's due to these lack of resources. So that was a limitation. We had lack of resources here in a low income area and a very rural area. So with that, we don't have abundance of fresh food that's available, and lack of physical activities that are available throughout the community as well. The third limitation was lack of motivation. The participants' lack of motivation to change was a challenge. The participating population was adolescents, requiring both the participants, the adolescents, and their parents or guardians to be motivated for change as well. This project involved the participants, and it was necessary for lifestyle adjustments that improved changes within the household. So not only this adolescent may want the change, but the parent and the guardian that they are living with in that house also has to be motivated to make that change. It all depends on, a lot of the foods that are bought in the house. An adolescent can't get out and go buy their own food. So it kind of depends on both parties, the patient and the guardian, to make this change in order for this to work. The project expected outcomes were consistent and similar to the anticipated impact of the project. The results proved that educating participants on the risk factors of increasing BMI and how to reduce BMI benefited patients' health outcome through weight loss, as we saw in that second graph that was seen. Due to the short time frame of the project and the time frame for successful lifestyle changes, the expected outcome was a minimum BMI decrease with the expected delay of acceptance to change. So the project did show an improvement in weight loss, but due to the length of the project, the slight decrease did not skew the BMI data enough to consider it statistically significant. The project was used to educate patients on risk factors associated with being overweight and obese, with the hope of improving health incomes of these adolescents. When looking at the implications of practice, I put together a little thing here that kind of shows what we implemented within the project and what the hopes were of the project. And hopefully, if this is implemented into other practices, this is what the outcome will be. So education on risk factors, education on why, education on motivation, education on how to reduce this BMI, plus the resources. We've got to have these resources. We need to have ways to have exercise, ways to have certain physical activities, whether it is community sports or recreational basketball and baseball and softball, whatever they may be, providing these resources to these patients to have them at hand. Whether it is food boxes in order to get healthy food shipped to their houses, they are needing these resources in order to be successful. And then motivation. We've got to have motivation in order to make a change. And this is anybody with anything that they try to achieve in life. You've got to have that motivation. You've got to have a reason of why we're going to make this change and why we need to make this change and what's going to happen if we make this change. And with these three things, our hopes with this project was to reduce the adolescent BMI. And with that, it would help reduce the risk factors of these chronic diseases that are created due to being overweight or obese earlier in life and later in life. And in conclusion, here's a quick recap This was a retrospective chart review that was conducted on adolescent patients ages 12 to 18 with the diagnosis of either being overweight or obese according to the CDC guidelines. The project aimed to provide statistical evidence by proving that physical activity and choosing healthier food options would help reduce adolescent BMI. To achieve this goal, education was delivered to the providers and participants that were involved in the project. The findings proposed that there were no statistical improvement in the BMI categories in which the participants were placed, but there was an improvement in the individual weight loss. Future studies with a more extensive time frame and a larger sample size may support the effectiveness of implementing additional education into current practices. The project identified the need for motivation among the patients and the family members. Future studies may require a focus on motivating this population with a different approach. So I hope everyone enjoyed this presentation on how to reduce adolescents' BMI in order to prevent further complications earlier in life. Hopefully this will be carried on through other practices and can be used through other practices so that it can help reduce and improve the quality of health and life of our younger generation. And here are the references that were used for this presentation. Thank you.